So continuing our discussion about the therapy for asthma class, in this video we will talk about the corticosteroids, and we will cover topics including the corticosteroids, mechanism of action, their pharmacokinetics, their use in asthma, their adverse effects, and precautions. And let's start by explaining why the non-steroid anti-inflammatory drugs can't be given in bronchial asthma, and that is because the NSAID'S inhibit the cyclooxygenase enzyme but not the lipoxygenase enzyme, leading to accumulation of leukotrienes, which are potent bronchoconstrictors. Now, to really understand this, first we have to understand this diagram. So the phospholipase are converted to arachidonic acid by the phospholipase A2 enzyme, and then the arachidonic acid is converted to leukotrienes by the lipoxygenase enzyme, or it is converted to prostaglandins, prostacyclin, or thromboxane by the cyclooxygenase enzyme, which is here. So the non-steroid anti-inflammatory drugs inhibit the COX enzyme, leading to less prostaglandin formed and less inflammation, but this would lead to all of the arachidonic acid here being converted to leukotrienes. So because the COX enzymes are inhibited, so there's only one way for the arachidonic acid to be converted, and that is to the leukotrienes, which are powerful bronchoconstrictors, which lead to aggravation of asthma. And we have a separate type of asthma, which is called the aspirin-induced asthma, and that is by this mechanism here. So we don't use the non-steroid anti-inflammatory drugs in treatment of asthma, but we use the corticosteroids. And that is because the corticosteroids work by inhibiting the phospholipase A2 enzyme, leading to less arachidonic acid and less synthesis of prostaglandins and leukotrienes, which ultimately lead to anti-inflammatory effect. So now the idea of corticosteroids is that they work here. They work to prevent the phospholipids from converting to arachidonic acid. So they inhibit this step here, which is the phospholipase A2. They inhibit this enzyme, leading to less arachidonic acid and less leukotrienes and less prostaglandins. And this means that we have less inflammation and less bronchoconstriction. Now, the corticosteroids also work by some other mechanisms to decrease the bronchial inflammation and the hyperresponsiveness. So the other mechanisms the corticosteroids work by include that they inhibit the B cell function, and this would lead to decrease the antibody release and subsequently decrease the antigen-antibody reaction. They also work to inhibit the T cell function, and this would lead to decrease mediators and cytokine release, and they inhibit the macrophage activity and stabilize the lysosomal membranes, leading to less inflammation, and they also inhibit the mast cell, and this would lead to decrease the histamine release and lowers the capillary permeability, and this means that there is less edema in the airways. And interestingly enough, the corticosteroids also work by upregulating the beta-2 receptors in the airways, and that is because it lowers inflammation. So less inflammation means upregulation of the beta-2 receptors, and this means that there is better response to the beta-2 agonist medications. Now, it is very important to understand that the corticosteroids work on nuclear receptors, and this means that they work on the cell genes to exert their effects, and this would require multiple processes including transcription and translation, and that would take time, so their onset of action is gradual and may take anywhere from several days to several weeks for maximal benefit, and that is with consistent use. Now let's mention some points about the pharmacokinetics of these medications. So there is oral, intravenous, and inhaled formulations. The inhaled formulations include liquid capsule formulations given through nebulizers, and they also include metered dose inhalers and dry powder inhalers. And some of the widely used inhaled corticosteroids include the budesonide, the fluticasone, and the beclomethasone. Now let's talk about their use in asthma. So the corticosteroids are used in acute severe asthmatic attack to inhibit inflammation. For example, the hydrocortisone is given intravenously to get a rapid effect in acute severe asthmatic attack. They are also used in the management of chronic asthma. So the inhaled corticosteroids, for example, the beclomethasone, is FDA indicated treatment of choice for preventing asthma exacerbation in patients with persistent asthma, and the regular use of these medications reduce frequency of asthma symptoms and decrease bronchial hyperresponsiveness and risk of serious exacerbations. The inhaled corticosteroids have minimal systemic side effects compared to the oral or the IV corticosteroids, but they require an appropriate inhalation technique, and that is critical for success of therapy. Now, the oral prednisolone or the dexamethasone also used in management of chronic asthma. Now let's move on to talk about the adverse effects. So let's start by explaining the adverse effects for the inhaled corticosteroids, and those are associated with much less systemic side effects compared to the oral and IV corticosteroids, but it may lead to some local side effects. So the inhaled corticosteroids may lead to dysphonia, and dysphonia is loss of the voice in 50% of patients due to myopathy of laryngeal muscles and mucosal irritation. And inhaled corticosteroids may also lead to oropharyngeal candidiasis, and that is due to the corticosteroids decreasing the mouth immunity, because remember, the corticosteroids are immunosuppressive, and this can be avoided by rinsing the mouth after each inhalation, and it can be treated by nystatin mouthwash or miconazole. Now, the inhaled corticosteroids also may lead to reduction in growth velocity in children using them, and these effects in low doses are small and reversible, but in higher doses they are significant. And the inhaled corticosteroids may rarely lead to cataract, glaucoma, hypothalamic pituitary adrenal axis dysfunction, and impaired glucose metabolism. Now let's talk about the systemic corticosteroid side effects, and those include the oral and intravenous corticosteroids. So they lead to systemic side effects including osteoporosis, myopathy, higher glucose levels, cushingoid features such as truncal obesity, buffalo hump, and moon face, such as you can see in this picture here. And they may also lead to suppression of the hypothalamus pituitary adrenal axis. That is why if these medications are given for a longer period of time and you want to stop them, they have to be tapered off. They may also lead to impairment in growth in children, and they may lead to infections, hypertension, edema, and arrhythmias, and they may also lead to ecchymosis, skin thinning, striae, and impaired wound healing, and many other side effects. Finally, let's talk about some precautions in corticosteroid use. So the oral or IV corticosteroids, if used for a long period of time, must be withdrawn gradually to avoid acute Addisonian crisis. And the corticosteroids lowers potassium levels, so the diet should be rich in potassium. And continuous check for any increase in weight or any edema or any sugar in urine or higher blood pressure is important because these medications lead to those side effects. And if the patient develops acute infection, the corticosteroids are the reason behind that because they are immunosuppressant. So the patient must be treated by adequate antibiotics and decrease the dose of the steroids. And with that, we reach the end of this video. Thank you guys for watching. Please give us a like, comment your ideas and questions, and subscribe. And this video is a part of a bigger class. It's called the Therapy for Asthma Masterclass. You can check it out. Link will be in the description of this video. Thank you for watching. Peace.